Okay, Kieran and Clemens, if you are back and able to turn your cameras on, I will start letting folks in as soon as we have you. I might be getting water. I'm going to start letting folks in, and Kieran and Clemens, just turn your cameras on as soon as you are back, if you're hearing that.
Good morning, everyone. Thank you for joining us this morning. We're giving folks a little more time to get into our virtual room.
Hi, everyone. Feel free to introduce yourself in the chat while we wait for others to join.
Good morning, everyone. Thank you for joining us this morning. We're giving folks a little bit more time. Feel free to introduce yourselves in the chat. We'll get started in a minute or two.
We're also curious, for those who are here already, to hear what types of questions you might have around CalAIM or work or conversations you're having related to the topic today, so that we can weave that in. So please share that in the chat. Hi, Karen. Hi, David. Hi, Karen. Hi, Jenny. Hi, Earl. Hi, Bridget. Hi, Anthony. Thank you all for joining us. Hi, Christine.
I think we have a good number. Should we get started?
Yeah, let's do it. That sounds great.
All right. Well, welcome everyone. I'm Tuli Martinez, Vice President of Programs and Conferences at SEG. Thank you so much for being here this morning. We're really excited to be able to dive into this very important topic this morning. Please introduce yourself in the chat box with your name, organization, and a question that you may have about CalAIM, or a brief snippet about the work that you might be already doing as it relates to this work. So thank you and welcome again. I see a lot of friendly faces, well, virtual faces. So anyway, good morning. I would like to introduce today's moderator, our friend and member, Bonnie Madura. She's Senior Program Manager at the California Endowment and has been super helpful and kind with her time and knowledge to help us put together today's session. So with that, Bonnie, I would like to introduce you to go ahead and facilitate our conversation today. We'll have some Q&A during the hour as well, and we'll be doing some updates from attendees and relevant work that you might be doing around CalAIM. So thank you. Bonnie, take it away.
Good, thanks, Tuli. Good morning, everyone. Nice to see lots of familiar faces and some new faces as well. So yeah, let's go ahead and get started. And I think we have some slides to pull up as we get started in this conversation. As Tuli said, as questions come up, please put them in the chat box. We will collect them and get to them at the end. We have a terrific panel lined up with some great speakers really doing, and we'll talk about the great work that they're undertaking and really live in the moment with CalAIM. So with that, you know, what is CalAIM? I know about a year ago, maybe a little bit longer, all right, the Health Funders group had a session on CalAIM, but just thought we'd spend a moment kind of refreshing for those who attended that. What is CalAIM? For those who are new to this, how do you really take a pretty complex reform initiative and give some high level overview to it. So CalAIM is the California Advancing and Innovating Medi-Cal. It is called CalAIM for short. It really is the first, I would say, pretty major reform for Medi-Cal in over a decade. For those, just a reminder, Medi-Cal provides health coverage in California to approximately 13 million individuals. Roughly a third of our state's residents are covered by Medi-Cal, and the annual budget roughly is about $25 billion. CalAIM has three primary goals, and I think the state started a planning process, gosh, almost 3 years ago maybe, to really start to work on the reform on CalAIM, and came up with what are the goals of CalAIM. So it's very much how do we sort of look at the members in CalAIM and really address the whole needs, whole person care, by really focusing on how do we start to address the social determinants of health for our members. How do we move Medi-Cal to a more consistent and seamless system by reducing complexity? For some Medi-Cal members, they encounter 6 different systems in accessing care as a Medi-Cal member. How do we reduce a lot of that in the program? Then how do we, improve outcomes, reduce disparities, and really drive some delivery system transformation by changing the way that, the services are financed? Those are the 3 goals of CalAIM. In order to do this, as I said, the state went through a 2-year-ish planning process. It got extended, COVID. The state decided to defer implementation by a year of CalAIM, but it was an important process. I think they had multiple stakeholder work groups going on around different aspects of CalAIM. Some of the aspects are moving forward on a faster timeline than others, and I know a couple of our panelists will speak to the ones that they're most engaged with. But to do this, the state has to submit what's known as a waiver to the federal government in order to seek permission to use federal dollars to support some of this innovation and reform. So it gets sort of complex in what those waivers are and how they're structured and done, but just it's an important note, and I know it'll come up later in the conversation. CalAIM is not starting from scratch. It's really building on programs. You may have heard of some of these that have been around, whole person care, health homes, coordinated care initiatives. So the state is not starting from scratch, really building on programs in existence and some reforms. And CalAIM will roll out with members with the most complex health needs first. So it's not January 1 of 2022. It's not going to roll out to every Medi-Cal member. It's going to start with those members who really have the most complex health conditions, and then eventually roll out to the full Medicaid population. As I said, the state delayed the launch of CalAIM by a year for very right reasons because of COVID. So now the new targeted date is January 1 of 2022. Next slide. So why should we as funders care? What brings us into this conversation? And we'll hear about this throughout our session this morning. Certainly, COVID-19 has not uncovered any new inequities. Inequities have existed in the health system, and COVID has exacerbated those. And as we look as a state to move forward, to build a system of health that really does improve health, we need to focus on equity. So I think a question for us as funders, and I know partners on the call here today, how do we center equity in CalAIM as well as some of the other health system reforms? There are other health system reforms happening. For example, the health plans that provide Medi-Cal services, they are up for rebidding over the next several years. Are there opportunities to build in equity into these reforms that are happening? Certainly for those who know the Medi-Cal program, it is one element of a very complex healthcare financing structure here in the state. And yet CalAIM, I think, is an important step towards financing what many of us probably have funded at some point, health-related social needs. If we have funded in housing, if we have funded in food security, if we have funded case management, some of these services that we as funders have been supporting now could be covered potentially under CalAIM. So shifting dollars towards some of these health-related social needs. And then certainly CalAIM is going to take a lot of strong bridges and partnerships between health plans and public agencies and healthcare providers, community-based organizations, social services organizations. Again, we have probably all been funding aspects of these kinds of organizations and these sectors. It's really going to take strong relationships to make this work, and it's going to look different. What happens in Los Angeles County, how CalAIM rolls out locally, will look different than in Ventura or in Riverside or Orange. So it's very much we'll take these sort of strong bridges and relationships to make this work. And luckily, again, I think different regions, there are things to start building from, and we'll hear more about that in a little bit. Next slide. So I'm pleased today we have three terrific panelists who really bring a different lens to their relationship with CalAIM. What does it mean for the role that they hold and the communities that they work with and such. So we have first Clemens Hong, who is the Acting Director of Community Programs for LA County Department of Health Services. Kieran Savage is Executive Director of California Pan-Ethnic Health Network, or CPEN. And then Wendy Schiffer is Senior Director of Strategic Planning for LA Care Health Plan. So with that, I think I'll turn it over to Kieran.
Great, thanks Bonnie and team, thanks for the invitation. It's nice to see everyone, or see your names anyway. I understand first thing in the morning, I don't like to have my camera on either, so I totally get it. So like Bonnie said, I'm Kieran. I'm the Executive Director of the California Pan-Ethnic Health Network. We are a statewide multicultural health advocacy organization. And what that means is that we work very closely with community-based organizations that are deeply embedded in communities of color across the state to advance state and local policy change that furthers health equity and dismantles structural racism. And so we have been very focused on opportunities to improve our Medi-Cal program because we do believe it is a really important piece of our safety net, very important, particularly for people of color. 2/3 of beneficiaries in the program are people of color, 1/3 are limited English proficient. And so we believe that our Medi-Cal program must be a tool for equity in order for us to advance health equity as a state. So we, in 2019, sort of knowing that this process was coming up and that the state was going to be looking at how to reform the Medi-Cal program, how to strengthen the program, so went into communities and did a lot of work really engaging with our community partners in community to understand what are, now that we're at a point in California where not all, but most people have health coverage, right? What does this mean for where we need to go with improving the quality of care and really making it work for consumers? So if we can go to the next slide, please. So actually, let's keep going to the next slide. I know I only have 7 minutes. So we did, this is just to give you a sense of sort of who we talked to. We did a series of focus groups, 6 focus groups across the state with different communities. So you can see the sort of target populations of the different focus groups, different languages, and different regions of the state that we spoke to inform our recommendations around CalAIM and around the Medi-Cal program and the broader healthcare delivery in the state of California. Next slide, please. So the key findings, there were differences from population to population, but there were also some very strong themes. And just to name a few, one was that consumers continue to encounter, I think, very clear barriers to accessing care that shouldn't exist today, right? Like consumers described how long it takes to find an appointment, how difficult it is to find a provider in their health plan's network, how far they have to travel for care. All of those kinds of access barriers are still quite prominent for consumers. Consumers also describe their difficulty navigating coverage systems. We know that particularly low-income workers tend to sort of churn through different coverage programs, right? Transition from Medi-Cal to Covered California to employer-based insurance. All of that is very difficult for consumers to navigate. The system is very confusing, and there's a lot of different pieces to it. And so people really indicated needing more support in navigating their coverage system, even understanding who their health plan is and what is the function of their health plan and how does that relate to their doctor, right? Those are really questions that consumers have. The other thing that really stood out to us was the level at which consumers described stigmatizing or disrespectful treatment from their providers. So we had consumers who talked about, providers making assumptions based on their sexual orientation. We had consumers who talked about feeling like their provider wasn't listening to sort of what they valued, right? What was important in their culture, their family, their community, making assumptions about their lifestyle, all of those kinds of things that really, I think, have a profound impact on whether consumers want to engage with the healthcare system, right? And what that looks like. We also, I think, were somewhat surprised to hear really serious continuing issues accessing interpreter services, and the number of consumers in our focus groups who didn't even know they had a right to an interpreter, I think, was striking to us, given how strong we feel our language access laws are in California, but knowing there's a real gap between the law and the implementation. And the final piece, which we have on here as poor patient engagement, but I actually think is like the ray of hope here, which is that, consumers really indicated that they want to be more engaged, not only in their own individual care, but in designing health systems, right? And that right now they sort of don't feel that the avenues are there to do that, but there was a real desire to be engaged in designing and redesigning systems, which again, I do really think is sort of a huge opportunity. Next slide, please. So we published a report that we can send out where we basically said, we think we have 6 big picture recommendations based on what consumers are telling us that should inform CalAIM and should inform Medi-Cal procurement, as well as how we design our healthcare delivery system. So the first is to really center quality in payment systems and in delivery systems. So that looks like embracing and investing in community-based care, right? And by community-based care, we both mean, our clinics that are really located in our communities, but we also mean types of care that are more defined and embraced potentially by people of color, including community health workers, doulas, dental therapists, etc. This also means we need to better prioritize, track, and report data so that we can reduce disparities, and that our health systems really need to implement equity as a strategic organizational priority. The second recommendation was to engage patients, families, and caregivers. So removing barriers to engagement in the existing quality and equity efforts, right? Using financial incentives as a lever to do that. And giving patients, family members, and caregivers real decision-making power in our systems, right? Figuring out, to us, equity means sharing power, right? And so figuring out how do we do that within a healthcare system and tying the feedback of consumers to payment and to quality improvement. We also recommended strengthening culturally and linguistically appropriate care. So really enforcing our existing non-discrimination laws, strengthening access to and quality of interpreter services, increasing the diversity of our healthcare providers, integrating equity and cultural humility into training and continuing education, and really leveraging new possibilities such as telehealth to expand access to high quality, culturally and linguistically appropriate services. The fifth recommendation here is to improve and integrate physical, behavioral, and oral health. And we particularly heard about behavioral health and the challenges with access there, and the need to have stronger integration with physical health or primary care, where people of color are more likely to report their behavioral health symptoms. So really investing in that patient-centered care model, increasing utilization of behavioral health services through a broad array of integration models, and expanding access to preventative care for behavioral and oral health through payment reform. And then finally, oh, not finally, sorry, there's 2 more. So You know, we really think a lot of this has to do with accountability too, and that I think goes a lot to the procurement conversation. But for all of these changes, we have to have better ways of holding health plans and systems accountable to meeting the standards that we set, and really tying those achievements to payment so that we can drive the changes that we seek. And then finally, for real this time, we do recognize the significant impact of social determinants of health and believe that health systems should invest in prevention, to more strongly linking health and social safety net services, and to really building local and regional collaborations and investments in community health. So what does this look like when we think about the opportunities that are right in front of us, CalAIM and the procurement process that Bonnie described? So if we can go to the next slide, please. Oops. Perfect. Okay. So in CalAIM, I think we would agree there's a tremendous opportunity. This is something where the state is taking a broad look at the program and thinking about how do we make it function better for consumers. It does set forth really, I think, a consumer-centered model of care, trying to cut down on duplication and confusion that consumers have to navigate right now. It acknowledges the importance of having sort of a multi-tier approach, both looking at population health and at designing services to meet the needs of the most vulnerable members of the program. And it does try to address social determinants, invests in things like housing, nutrition, asthma prevention services, and there are also very significant reforms related to behavioral health. So these are some of the opportunities that we see. Next slide, please. But there are some challenges we feel with the way that the redesign is framed. First, we would say we do think there's a lack of investment in prevention strategies, as well as in quality improvement and disparities reduction for consumers who are not sort of that top 5%, which is really where the state has focused a lot of this. It's around the 5% of beneficiaries who currently use the most services, which we do believe really kind of overlooks people of color who may be less likely to use services even though they have a need, right? And so that we need a stronger approach to quality improvement across the program. CalAIM also does transfer a number of responsibilities to health plans, some that counties are currently holding. And we're not, you know, we don't feel that it currently has the commensurate oversight and accountability to make sure that that is a successful transition. We also feel that it doesn't address some of the key barriers to equity, such as demographic data collection and reporting, where we've really had a gap, and that has impeded some of our efforts to really do value-based care because we don't have the right data to be able to look at racial equity. So without addressing that sort of head on, we think it might be difficult to achieve some of the other aims of the program. And then finally, you know, there's a lot in the proposal that talks about the role of community-based organizations and communities, but there are significant unanswered questions around really operationalizing that, right? You know, how will CBOs be integrated into the contracting process, for example? So I think there's a very good intention there and a lot of details to be worked out. Next slide, please. So this is very much tied to procurement, which is where we feel the sort of the rubber meets the road in terms of operationalizing CalAIM and being able to really accomplish what we're setting out to accomplish in the waiver, because this is where we're setting the standards for what kind of health plans participate in the program and what they must do to serve Medi-Cal beneficiaries. So we have basically 3 big recommendations for how we can really advance equity through procurement, which again, very tied to the CalAIM policy changes that are happening. So I think the first and maybe biggest is to really tie payment to disparities. We know that policy changes, culture shifts often follow the money, right? So we really do need to tie how we pay health plans to the actual attainment of reduced health disparities. We need to embrace and invest in community-based care, including community-defined practices for mental health, for birthing, for traditional healers and substance use. And we do need to address the social determinants of health through a prevention and population health strategy. Next slide, please. And then I'll just say, I think there's some complementary efforts here to what we're talking about in terms of the opportunity to really make real some of these changes. So just to say very briefly that, you know, the governor's May revision that was released on Friday does contain the addition of community health workers and doulas to the Medi-Cal program. So that's very tied to one of the key recommendations that we had around community-based care. We think that's a huge step forward, super excited about that. And the governor's May revision makes a couple of other expansions in terms of coverage. One is to expand Medi-Cal eligibility to all, regardless of immigration status, 60 years and above. So we'll still have a gap between 26 and 60, but we're getting closer. And second is to align with the federal changes and to extend postpartum Medi-Cal coverage to 12 months. And then I'll just leave here that there's also a lot of money coming down from the federal government, both state and local, where we think there's tremendous opportunity, but I will leave that there and let Bonnie bring that in at the end. So let me pass it back to Bonnie.
Good, thanks, Karen, and thanks for, I think, making an important connection, right, between CalAIM and the reprocurement process and these other opportunities as well. So good. So with that, I think I'm going to turn it over to Wendy now and really give us a sense of, you know, what does CalAIM mean for LA Care?
Let's see. Okay, you can hear me now, right? Okay, perfect. I just got a little sign, unmute yourself. So I'm Wendy Schiffer. I am Senior Director for Strategic Planning at LA Care, and so strategic planning kind of encompasses our enterprise-wide, like all kinds of catch-all stuff, but in particular, our community benefits plan is under me as well, so I'm sure most of you, if not all of you, know Roland Palencia. Everybody knows Roland, so he's on my team, and so I come at this from the health plan perspective, but also as a funder too, because our community benefits plan is our grant-making arm, so interested to, and also just to give you a word about LA Care, just because I know, just especially, you know, coming off what Kieran just said, there might be like, I don't know, a slight amount of trepidation that, oh, this is very health plan focused, but LA Care is not a traditional health plan. Like, we are a public agency. We have like about 2.4 million members. Most of them are Medi-Cal, but also some are in Covered California. We have a dual plan for dually eligible Medi-Cal and Medicare, so that's our CalMedi Connect, and we also have a product for in-home support services workers. So, but our population is for the most part low income, and we are a public agency, so we have a board which represents different stakeholder groups. We also have a consumer advisory panel, so hopefully we have the same goals as what you just heard. So we could just go to the next slide. Okay, I'm not really going to go over this because I feel like Bonnie went over it already, but just like, you know, what is a waiver? It's permission to change the way we operate Medicaid. It needs to be approved by the federal government. And I'm just going to skip over this because Bonnie already went over the goal. So let's just, but you'll have it when you get the deck. So let's just move to the next slide. Okay, I do not expect you to understand this slide because there's a lot of acronyms on it, but it's really just meant to give a picture, just an illustration that there's a lot of components to CalAIM, and some of them are bigger lifts, some of them are lighter lifts, and it takes place over time. So we just did the schematic for ourselves at LA Care just to kind of give a picture of like, these are all the pieces, here's when they're rolling out, and the size of the font is like how big a lift it is for us. So we're involved in all of it, or most of it, but some of it we don't have to do a ton for, and others we have to do a lot for. So just to go over the acronyms, ECM is Enhanced Care Management, and in a couple slides, and I'll explain a little bit more about them. But Enhanced Care Management and ILOS is in lieu of services. Everybody always refers to them by their acronyms. And so those are kind of like the hugest, I think, what we're collectively talking about the most today. So I'll come back to those, but those are effective, or parts of them, in January 1st, 2022. So a lot to do in a short amount of time. PHM is population health management. It's also very, a lot of work for the plan, but a lot of it is stuff that we're already doing. So it involves a lot of risk stratification, using data to look at our population, looking at screening forms and sort of imposing some continuity and consistency about screening tools that plans use. So we're already doing a lot of it, like we're already NCQA certified. So we're a little bit ahead of the game. Not all plans across the state, public plans are. So, but there's still just a lot of data issues that we are, thinking about and working on. DSNP involves, so the Cal Medi-Connect, which is the state's pilot for dually eligible members, that is sunsetting, and so plans that take care of both Medi-Cal and Medicare have to have DSNPs. DSNP stands for dual eligible special needs plan. So we used to have a DSNP, and then when Cal Medi-Connect came about, we just decided, well, it doesn't make sense for us to have both of those products, so we just did Cal Medi-Connect. Now it's ending, so we have to reactivate our DSNP. So that's a lot of work. It's setting up a whole new health plan product. And then 2024, an RFP for full integration plans comes about. A full integration plan would be a plan that combines everything. So medical care, dental care, behavioral health, like everything is just one plan. So an RFP would come out, and actually if you go to the next slide, it just continues the timeline. It would be effective 2027. And personally, I'm like, why would we ever want to apply for that? But yet others at LK are like, no, of course, like it sounds very exciting. So again, something that sounds very exciting, but so much work to make it work. So that's just on the horizon. Luckily, it's not in the short term. So I just wanted to give you a sense of the kind of complexity of all the different pieces that are involved and what we're working on and what we're thinking about, and the phasing and timing of it. So if you move to the next slide. So this just goes a little bit more into enhanced care management and in lieu of services, what they are and how they would work. So I'm just going to refer to them as the acronyms, but at least I've explained what they are. So ECM, it would be a statewide Medi-Cal benefit that basically would replace whole person care and health homes. So like either Bonnie or Kieran said, I think Bonnie said it, we're not starting from scratch. There already are programs that this is based on, but yet it's not the exact same thing. It's not just like, okay, now it's called CalAIM. Like there's slightly different, they don't call them target populations anymore, populations of focus and slightly different services. So there's a lot to do. It's not just, just like I said, flipping a switch. The funding, as was mentioned, is going through the health plan. So a lot of just involvement of the health plans. Health homes went through the health plans. Whole person care was through the county. We've been very involved, but so it's just a slightly different model. This will bear a lot on our conversation after our presentations, but services are provided through another acronym, CBCMEs, which stands for community-based case management, or I forget if it's case management or care management entities, similar to the health homes model. So care really is provided in the community. And just on to that matter, as LA Care, a public plan, all the community clinics are part of our provider network. DHS is part of our provider network. So we already do provide a lot of community, centered care, and a lot of those entities are CBCMEs. So there are 7 required populations for ECM. Again, it's like similar to whole person care and health homes, but not exactly the same. As was mentioned before, it really starts with the highest need populations. And then this is like a way oversimplification, but some of the required ECM services, include care management, integration of different services, connection to social services. So it really does take that social determinant of health approach and like, how do we make care more holistic so it's not just medical care, that's it. Then in lieu of services are combined medical and social services with the goal of avoiding that higher level of care, hospital stays, nursing facility stays, emergency room care. So the idea is, you know, if somebody gets this social service, they can stay out of the hospital. And there's a menu of 14 different in lieu of services that plans can offer. They don't have to offer all of them. And, you know, potentially they could be phased in. There's still a lot of things to be decided, but just to go over just the biggest challenges are timeline and funding. So just for the services that start January 1st, 2022, there's just a lot to do to get it set up. There's a lot of unknowns. We have been very engaged with other stakeholders, with the county, with the state, and just trying to get definition around who and what and when, and then just funding. I just need to just mention funding because, like I said, it's not exactly like health homes, whole person care, exactly like everyone that's in it, it's gonna have a new name now. There's not as much funding in the system. So it's like there's an expectation to provide those services. Nobody wants anybody currently receiving services to get cut off from those services, but yet there's not as much funding in the system. So that is just something that needs to be figured out and addressed. And, you know, how does that work? And in lieu of services, I am not a super expert on the financing, but in lieu of services, it's not like just, well, actually, just go to the next slide. And I'll make my, so this is the menu of the 14 different in lieu of services that you could choose. And you can't really read all the little symbols, but some of them already are health homes, in health homes, some are in whole person care, some are new. But just to take like medically tailored meals, for example, it's not like the state is going to pay us to do medically tailored meals. It's like there's some money associated with in lieu of services, but in some cases it's just like, okay, health plans, you pay for it, you're going to save money later with reduced hospitalizations, and eventually, like, you can count it as a medical care cost, and eventually it will get built into your rates. So, I mean, it sounds great, but how is it really going to work? And is there really going to be enough funding in the system to pay for everything that needs to be paid for? So with that, I think I am going to stop and, you know, save the rest for the discussion.
Great, Wendy, thank you. And really thanks for, I think, giving us a glimpse too of the complexity of what the health plan is working on around what implementation, you know, means. Clemens, I'm going to turn to you now, and I think really, you know, have us, you know, give us your perspective on what CalAIM means from your vantage point in the county.
Great. Good morning, everyone. I work for the County Department of Health Services, and I serve as the lead on CalAIM for the department. I also sort of oversee Housing for Health, the Housing for Health program, the Office of Diversion and Reentry, and our community partnerships group, which includes our community engagement work, the My Health LA program, which is our sort of LA County insurance for the uninsured program to fill the gaps, and the smaller community partnership programs, which include things like the medical legal partnership. So that's kind of my, so thank you so much for having me. I'm actually interested, and I'm probably the closest to the ground on some of this stuff, but I think my points are going to be a little bit higher in some senses using examples from the ground. So just so you're not surprised. So there's so many facets of the May revised budget, the ARPA allocation decisions and CalAIM proposal that impact county delivery systems. It's really just, there's so much moving. It's overwhelming in many respects. And I'm sure as we walk through this, many of you will be overwhelmed, and that's okay. And I think there's a lot of uncertainty and things that are still being figured out. So I wanted to just give some high level thoughts on CalAIM, and then I think in the discussion, we can sort of talk through some of my thoughts on how funders might support some of the efforts, and hopefully we can have a nice broad discussion. So CalAIM, or the Medi-Cal waiver program, including recently proposed changes in the May revised budget, represents really a shift to managed care. that has been going on for probably the past decade in an attempt to expand coverage for various health-related social needs and build infrastructure to improve care coordination to the sickest, most marginalized individuals. So it's this construct of complex care management, the 5% that account for 50% of costs. How do we sort of rein that cost in and provide better care at the same time? It includes obviously some programs for the uninsured, which I want to not miss, including state-only Medi-Cal expansions, which were talked about earlier for 60 plus now, and the global payment and for pregnant women 12 months postpartum, and then the global payment programs, which have been in there since the previous waiver. Enhanced care management, which Wendy summarized very nicely, represents an expansion in benefits, right? So it adds complex care management is what I would call it, or we'll just call it enhanced care management to simplify things, or this construct of care manager of care managers. So one care manager to rule them all, so to speak, as a benefit for the top 1 to 5%, depending on how you think about the funding of Medicaid beneficiaries by cost mostly, but acute care utilization being a part of that. These are individuals that generally have multiple physical, behavioral health, and health-related social needs that drive poorly coordinated care, often high utilization of healthcare services, as well as justice and social service systems, poor health outcomes, including premature death. The state also intends to expand Medi-Cal benefits over time through the use of pre-existing managed care provisions that enable managed care plan flexibility, right? To use capitated funds, right? Already funds that are sort of embedded there to support lower cost services that may not be Medicaid benefits in lieu of higher cost services that are. So successful in lieu of services programs, which again, Wendy summarized nicely, would be transitioned to Medi-Cal benefits in coming years. And this is an explicitly stated part of the Medicaid office's strategy, DHS's strategy, that in lieu of services that are put forward, the 14 services, they really want to test and explore whether those are things that should become benefits in 5 years. And it's an important thing to kind of note, because it's also a system for continuing to do this over years, right? As we sort of move into managed care and value-based constructs, it's things that can continue. We can continue to identify new in lieu of services, prove that they are really cost savings, and then and think to move them into Medicaid benefit systems. So it's a Medicaid expansion strategy. So 2 examples that I just will raise from our thing as a recuperative care. So we launched 1,400 recuperative care beds in whole person care. Those recuperative care beds, we can discharge people from the hospital, persons experiencing homelessness more easily and earlier, and in lieu of extra hospital days, right? Another example is the Enhanced Residential Care Program, which was also funded by Whole Person Care. And most people know this group of sort of this system as board and care, right? So we provide enhanced services so people can remain in the community, be community dwelling in lieu of being in long-term care facilities where the costs are much higher. So the idea is that by shifting the costs into these settings, we can continuously pay for enhanced residential care, because every day they're in that, we're averting a long-term care cost that would have cost health plans, many, many more dollars. So that's kind of the construct in the in lieu of services space, and that really that move to Medicaid benefit is really a critical piece of that. So the need for funding in these areas is immense. And I think what you heard from Wendy is that the investment is likely to be very inadequate in the next waiver. And so if you just think about the people, the individuals that need these enhanced care management services, these are, and we've been touching all around this. This is equity, right? These are victims of structural violence and lack of investment in our communities, particularly poor communities of color, that have led to generational and cumulative lifelong trauma, right? That lead to suffering from serious mental illness, substance use disorder, homelessness, justice involvement, cycles of incarceration and death, all together, right? These are in one individual. You see this over and over again. There is a moral imperative and an urgency to act in this population, but the cost is also large, right? And with almost a fifth of our GDP going into the sick care system that doesn't provide care, half of which are borne by this top 5%. So if you just think about the confluence of what I just reviewed very quickly, just what we need to do to solve this is not going to be solved by Medicaid alone. And that's a point that I want to make, that CalAIM is a well-meaning effort, right, to really think about population management approaches, to work upstream, starting very specifically with the sickest, most costly and marginalized individuals. And with a vision, right, which we just talked about, for moving towards building a foundation for value-based payment and health delivery. But we're not going to get there in 5 years. And the investment that we're putting in is not there to get there, right, in 5 10, maybe even 20 years. There's going to have to be a braiding of funding and a real look at how we're taking resources that are available and rationally allocating them to address these issues. So over the next 5 years, it does not look like we'll have sufficient funds to really move to value, to make the investments necessary. And so there's a lot of work to be done. And so the waiver plan, as a result, includes a high dependence on local funding initiatives to sustain the progress that we've made in the last waiver. So programs like whole person care. The county investment, which was matched through whole person care, so remember, it was a 50-50 matching program in LA County, led to really large investments in infrastructure, including housing infrastructure. So we added 1,000 recuperative care beds, right? Over 1,000. We added 500 beds of enhanced residential care. Almost 13,000 people are now permanently housed, right? As well as a new diversion reentry program, pre-release infrastructure in our jail to better coordinate care into the community, post-release infrastructure where we've partnered with community-based organizations, including with the hire of over 125 community health workers with a history of lived experience of incarceration, right? All these sorts of investments in IT and data sharing, other workforce investments, including, just speaking back to Karen and the budget, the doula program. We actually funded a doula program in 3 of our highest risk areas in LA County, areas with the highest African-American infant and maternal mortality, right? So these are all programs that some of them have pathways, but they're not going to fund the full scope of what we do, right? So just to give you one example, we have 13,000 people permanently housed. It's possible that only a small percentage of these individuals will receive the housing navigation, tenancy support, and enhanced care management housing benefits, right? Which means they still need supportive housing. And if they lost that housing service, they would be in our hospitals again, right, in a month. What are we going to do? Well, we have to use Measure H, which we're thankful to have in LA County for at least another, I think it's 6 years, to braid in and support this funding, with the hope that over time we'll be able to convince our health plans, Wendy, to fund these things, or expand obviously the rates, which is the critical piece to be able to include this work. So avoiding major steps back in these advancements will be hard without a major commitment of funds, is just the bottom line. We need managed care to commit these funds. There's incentive buckets that last for 2.5 years to sort of do that, with the hope that we can find a bridge to more sustainable funding plans. And so I think the state has realized some of this gap in recent months. So I do want to call out a couple things in the 11-15 portion of the waiver that I think are realizing that some of these programs, as an example, won't transition perfectly, because health plans may make decisions not to initiate programs at the scale that we need for 2 years, or we may need to demonstrate something in the next year, or there are set timelines for initiation of programs. So for instance, the reentry enhanced care management benefit doesn't start until 2023. In LA County, it's supposed to start in 2022, but there's a whole host of reasons why the work that we've done, that we do in the county today, may not be sustained through the funding stream that is available. And so they've put into place this set of things, providing access and transforming health, so PATH in the 11-15 waiver, as well as a justice involved support program that we're really working with the state to try to create some bridge opportunities of funding. The health plans also have an incentive support that they receive that has received pretty significant funding from the state. Those set of incentives will be critical to bridging programs, as well as continuing to build the infrastructure that we need statewide to be able to do and offer these types of programs long term. So that all said, we will have to make progress, and I think we will, in partnership with the health plans. I think we've been at the table. It's, we are on the same page. We're trying to do what's right for our community and our residents. I think there's a lot of work to be done. I think there's a few things that I'll just highlight that we need, and kind of sort of a pseudo conclusion and a launch for discussion. I think we need to make that upfront investment in programs and infrastructure through the health plans, and braid funding from state and local sources to address the deeply rooted factors, right, that determine health in Medicaid and uninsured populations in our communities. And we have to do that, and we have to figure out how to braid that fund efficiently and try to deliver value. I think Karen mentioned this, we need massive transformations of our IT systems, our data exchange and systems, investments in how we do that, transparency about those measures, equity measures, as well as just basic care management relevant measures that we need to provide in real time, right? To really sort of be able to target our interventions. We need advancements in data analytics. This is a very underdeveloped space. And I don't know, Wendy, if you'd agree, but it's in health plans and healthcare systems alike, it's very underdeveloped, but we need drastic improvements in this. We need to be intentional about studying what we do. And this is partially to convince the actuaries and the CFOs, but we need to ensure that the value-based improvements that we make in Medicaid in lieu of services that are not benefits are moved to benefits. And the way that we do that is we have to demonstrate the benefit. And if we don't study it, it's gonna be hard to demonstrate. It will require a huge operational investment up front, which kind of goes back to my first point, but it's gonna be critical to evaluate it. And I think part of that is gonna be a development of a co-development of an evaluation framework, right? That involves multiple stakeholders, that has a mindset towards value-based improvements in Medicaid, but also, as we started the conversation with, a mindset towards collective impact, right? How are we impacting the health of our communities? So beyond Medicaid, right? And finally, we need to engage in and invest in community and community partners. Something that we don't do enough, and we don't actually know how to do well. And to do this well, we need to share power, we need to build capacity and invite true bidirectional communication and governance. And we're so far from this that I think we need to start to take the baby steps. You know, and we'll need to bring in a lot of expertise, subject matter expertise and technical assistance to do this well. I certainly don't know how to do this. A lot of leaders and systems don't know how to do this, but it's such a critical piece to bring that voice in, whether it's through human-centered design principles or just, you know, true community engagement principles where we can share power. And, you know, when we get, and I'll speak just straight for myself, when you get the $1.5 billion over 5 years to run a whole person care program, and you're forced to launch it without community input because you had 1 month to respond to the state application, there's a problem, right? And that problem needs to be solved if we're ever going to get past the issues of equity that we see. Because we're basically feeding and perpetuating the structural violence that we have in our communities. So we as a county are ready to move, and we're happy to be here. And I'm happy to go into, as people, we can go into specific areas of our priorities as we sort of talk through kind of funding opportunities and things. But I do want to stop and make sure we have plenty of time to kind of move into the conversation. So I'll just end there. And excited to kind of continue the conversation.
Good, thank you, Clemens, and just, yeah, appreciation again to Wendy and Kieran. I see some questions starting to come in, and Clemens, you sort of teed up my first question, which I've been really dying to ask. Kieran, you raised it in sort of, you know, what the focus groups and work you all did, and I think it's come up in each of the conversations around community engagement or consumer engagement or voice, bringing voice, greater and more, you know, diverse and different voices into the conversations. I'm going to contain it for a moment just to CalAIM. I know there obviously it's not, you know, it in and of itself is connected to many other things, but just what are a question for any of the panelists, sort of where are you seeing places where we can, Clemens, I think you maybe offered a couple, but really where we can bring greater consumer and community voice into, you know, implementation of CalAIM or additional planning that is happening. And I think really at a local level too. I mean, certainly, you know, LA is well represented here today, but Ventura and Riverside, Orange, other counties, sort of talk to us funders about, you know, how do you see community voice potentially coming into further conversations around CalAIM?
Yeah, I mean, I'm happy to start and just say, I think what you sort of left off with, Bonnie, is really important, that I think this really happens at the local level. And I think it happens in local collaborations. And I do think there's going to be two really important pieces. One is that health systems are have a willingness, right, to share power with consumers and communities and to give people real decision-making roles. I think what we do a lot of is sort of advisory, we survey people, and I think that's important for information gathering. But for real systems change, I think as health plans and counties and health systems, think about how to really operationalize the CalAIM policy changes at the local level, I think it's going to be really important to think about some kinds of shifts in governance structures that can give consumers a real voice, a real seat at the table. I mean, it's some of what we think about when we look at, the governance model of federally qualified health clinics and having to have, 50% plus one of the board, right? Things like that I think really lead to a consumer-driven process. I would say the other thing for funders is actually funding community engagement, right? Like there's nothing in CalAIM that puts dollars on the table to really bring consumers in to design the process. And I think that's the part where philanthropy can really supplement and support, both with your dollars, but also with your relationships with community and community-based organizations.
I would emphasize that last piece, because if you're going to bring community to the table, you need to pay them, right, to be at that table, to value them, and you need the structure in place to really invite that voice in a safe way, because these conversations can be triggering. There's all sorts of issues that develop, and there's a lot of opportunity there to think about how we do this right and well. And I think we need experts to sort of help facilitate that discussion. And a lot of those experts are not going to be county employees, right? And so I think that's a huge piece. I'll use one example just because I do want to sort of fold in, like one of the programs that we have is an enhanced residential care program, which I mentioned, that the board and care sort of constructs. The state is moving towards a managed long-term services and supports benefit, right, in the next 5 years, like in 2024. These are individuals with all the issues that I talked about earlier that have significant disabilities and trouble with activities of daily living that would potentially be placed in long-term care. However, there's no long-term care for a lot of these individuals. Like we can't find them. So they sit in our hospitals for 90 days or even a year or more. So we've been moving them into enhanced residential care in the communities and thinking about what are the supports we can put into place. And so an example now is we're starting an occupational therapy program, right? Which occupational therapists work with individuals to maximize their function. So can we move people from enhanced residential care with appropriate intensive occupational therapy into just permanent supportive housing? Or can we determine who needs the long-term care and aren't going to do well in? And so as you think about this sphere, right, how do we bring community into that process as we move towards a benefit, right? At all levels, at the local level, as we talked about, in terms of designing our care. And I'm not just talking community members, which are critical, but also the board and care service providers that are closing their doors and shuttering all over the county because they don't have funding, right? So how do we bring all of those stakeholders to the table and start to think about what an MLTSS benefit could look like that would work for these community members in a human-centered way? And then at every level have that layered in so that when the state goes to propose something into 2024 or whatever, or 26 or whatever the date is, that we've had that community input as well as the opportunity to work on a program that we think will reduce Medicaid costs immediately, right? And improve that over time to be more equity focused and more engaged. So just an example that might illustrate that from my perspective.
Yeah. I also just wanted to just say that advocacy needs to come at a whole bunch of different levels, because like what you were saying, Karan, like our board already is a stakeholder board representative of safety net providers and consumers. And we have 11 different regional advisory committees. So we have a lot of community voices, but they don't live, breathe, health policy. So it's like we talk to them, we hear them, we listen. But I also, not to age myself, but I worked for Department of Health Services when the very first 1115 waiver came about and was being negotiated. And we had advocacy organizations like legal services organizations and just like strong advocacy. They practically lived in our office space. They were with us every step of the way, really helping to shape that first waiver. So I'm like, listen to the people most affected, consumers, providers, but also bring in the advocacy groups that know how to do this and are very familiar with state policy and can really push things the way we need them to be pushed. Because sometimes an inside-outside strategy is definitely needed.
Great, I appreciate that perspective, Wendy. We have a question from Rose at California Community Foundation, wanting to know how LA County is involved in the serious mental illness, serious emotional disturbance demonstration opportunity mentioned in the CalAIM proposal?
Part of it is because Department of Mental Health is not here, and they are the ones that, you know, but I know our behavioral health department is working very closely with Department of Mental Health on the different behavioral health aspects of the waiver, but they're the ones that do the serious mental illness component.
I mean, the one place where there is overlap that we could speak towards is the enhanced care management benefit for behavioral health. And I do think that there is, and also the services that are needed. So there are some internal discussions we're having at the county level with mental health. And I know the health plans are discussing with them as well as to how do we better coordinate services, because there's a lot of specialty mental health care needs for the populations that we're talking about. And so like I think that's a place where we can, if there's further reason, we can sort of dive in there a little bit more. But I think, yeah, the broader, especially mental health sort of pieces are harder to discuss in detail.
Good. Okay, and maybe we can carry that question back to DMH and as a follow-up. So I know we're coming upon sort of a transition to some more member networking, but just wanted to ask you all, I've heard some different ways, you know, how we as funders can get involved, you know, locally in the county we might be in, or regionally around, you know, community engagement or consumer engagement, obviously recognizing the dollars that are in CalAIM are not enough to do, I think, all that we hope to do to move the system towards greater equity. But just would love maybe a thought from each of you, you know, ways in which, you know, funders might continue to engage, whether it's through funding or relationship building or such that you want to leave with us.
I liked what Clemens said about evaluation, because that's always something that's very, very much needed, but not built into the program. I know we also, well, before Health Homes started, we funded some kind of infrastructure grants to the potential, like the agencies that were likely to become the CVCMEs, just to help them with startup costs. Now, I mean, that's not exactly necessary right now, but we still are funding a little bit of transition, like grantees that we have that provide things that might be in lieu of services, but in lieu of services doesn't start right away. So kind of some transition, bridge, you know, infrastructure funding.
Yeah, to build off of that a little bit, I think organizational capacity building or development is a big need across the sphere. So I think you can both think about it in terms of our community-based organizations that are contracted to provide housing services or these in lieu of services, as well as our primary care practices that need quite a bit of support in terms of transforming their practices to really do a good job implementing things like ECM or enhanced care management. And I think that as we do that, it'd be great to sort of emphasize the need to really think about CBOs that are small mom and pops that are often the most deeply rooted in our communities, that usually don't get that contract with the county because they don't have the health insurance, or they don't have the insurance requirements, or they don't have the bandwidth or capacity to sort of manage it. And I think there's a huge opportunity to bring some of those entities up to participate in these programs down the line. I'll also mention workforce development. I know many of you guys have funded that. Community health workers, substance use counselor pipelines, which we have just a massive shortage of substance use counselors, and other multidisciplinary components of teams. We've talked about IT and evaluation, but just kind of the constructs around how do we sort of accelerate the development of the data sharing kind of pieces. And then I'll just leave you with one other kind of thought, which is, I think, what are the ways in which, you know, the group can sort of support and advocate capital investments and ongoing funding for services and operations in the housing and justice space. And I think there's a massive shortage. We all know that we're housing 2 people a day, and 2.7 people are becoming homeless every day. So how are we going to tackle that problem without more resources? So, you know, a question we might ask is, how can SCG work with the county health plans right, to help solve homelessness in LA County, right, by coordinating, inviting investment and maybe a massive trust fund that would fund 5,000 to 10,000 people subsidies for their lives, right, and the supportive services, like $1 billion with in a trust fund that sort of does that would, you know, big, hairy, audacious goal, but like that would actually go far for providing 10,000 people with housing in perpetuity and some of the sickest folks, and ideally would be paired with our flexible housing subsidy pool with federal vouchers that are coming and some state investments. But it would, the issue is we have a lot of interim housing beds, but a lot of people sitting there for 9 months because there's no permanent supportive housing outlets, right? So if we could tackle a big, hairy problem like that, then you could increase the throughput to the whole system and better utilize our interim beds as well. And so I think, you know, a key area that we might be able to think together on things like that.
And I agree. And the things I would add, you know, we've already talked about the community engagement and support for communities and community-based organizations to engage. The two pieces I would add is I think around support for planning. And I think about, you know, this new community health worker benefit, which sounds so simple, but there needs to be, I think, such intentional planning around that and really supporting community health workers to be at the table around how that is implemented. I think those are not things that the state necessarily puts dollars on the table to support. So I think that would be helpful. And then the final thing is around collaboration. I think what we really believe is that there needs to be sort of this multi-system collaboration, both at the state level and at the local level, and that it's really hard to get people to collaborate without incentivizing it, right? And so how can funders sort of create and those tables and incentivize the various stakeholders to participate and to be there and provide them with the support to do it?
Great. Well, thank you for that final wrap up, at least for this session, and just Wendy, Kieran, and Clemens, thank you for being a part of the conversation, for sharing sort of what CalAIM means and opportunities and challenges you all, you know, see on the horizon. I know we're going to transition now, but I invite you to hang out and stay around and be part of the conversation. And with that, I think I'm going to turn it to Katie.
Thank you, Bonnie. At this point, we are going to transition to attendee updates. So I invite you, if you're able, to turn your camera on and switch to gallery view if you'd like to see folks. We just know that we are really missing the hallway conversations that would normally take place after this stellar panel, and so are trying to build in a little bit of time at the end of each of our programs for folks to share updates. It could be something that you're thinking about related to this. It could be questions that are coming up for you. It could be things that you're hearing from partners. We just know that there is a wealth of expertise in this virtual room, even beyond our speakers. So our speakers, I think, are able to stay and can be part of the conversation. But I invite you to raise your hand if you have an update or a thought or a question you want to share, or things that you're thinking about related to today's topic. So Sarah, I see a hand raised, and we'll start with you. Thank you so much.
Sure. Thank you so much, Katie. And thank you for that really engaging and interesting conversation related to CalAIM. My name is Sarah Steenhausen. I'm with the SCAN Foundation. You know, our foundation focuses primarily on improving the continuum of care for older adults so that people can age with dignity and independence. And we do a lot of work at the public policy realm. And you know, we worked both on supporting the state in implementation of the Coordinated Care Initiative. Now we're also working on different elements of supporting the CalAIM process. And I just wanted to kind of highlight a few of the areas that we've been able to make, I think, very strategic investments in this area. First is kind of building off of a lot of what Clemens was talking about, the really critical importance of building capacity. And some of the capacity building involves, you know, developing partnerships between health plans and community-based organizations. Both community-based organizations and health plans haven't traditionally worked in the same realm. You know, health plans don't often know who the community-based partners are, and at the same time, the community-based organizations aren't familiar with how you kind of develop the business case and contract for services with health plans. So, you know, several years ago, we started with a linkage lab that brought together aging and disability service providers with health plans to think about how you can develop partnerships and capacity. That has since grown into and an Aging and Disability Business Institute that is run out of the Federal Administration for Community Living. So it's trying to develop kind of a lab of thinking and program planning for how you can build partnerships with aging and disability with the health plan community. But the second is, building capacity within the health plan community as well, because we know that this transition in CalAIM, in particular for the dual eligible individuals who are Medicare and Medi-Cal, transitioning from the Coordinated Care Initiative to a statewide MLTSS system, as Clemens was talking about, will be a pretty significant transition, as will the transition to a new model of what's called the Duals Special Need Plan for Medicare, Medi-Cal individuals. So we're working to try and assess how we can provide the technical assistance with the state that the health plans need to be able to be prepared for meeting the needs of this population as CalAIM and in particular this MLTSS and DSNP component are implemented. Finally, I just wanted to highlight the role that foundations can play in evaluation. For the Coordinated Care Initiative, we were able to really focus in on trying to get real-time evaluation. So looking at beneficiary feedback as the program was being implemented, as opposed to typical evaluations, which don't come out with their reports till 3 or 4 years later sometimes. So what we did is we actually contracted for some polling work to assess beneficiary experiences with the Coordinated Care Initiative and the CalMedi Connect in particular. And we were able to use those findings to inform the state's understanding and try and adjust the procedure or the process along the way. So those are just a few examples of what we've learned in how to kind of tag on to what the state is doing and engage the community in the process.
Curious if any of our speakers or anyone else in the virtual room have any reflections.
I think with the evaluation comment, the real timeness, the kind of learning health system-esque kind of approach to implementation research is really the way we need to go. I think, these studies that are done with NIH funding, with efficacy trials that are done in small settings, you need to really be looking at this at scale, at a system. And it's something, we really are looking at in our housing and justice spaces to think about how we can sort of develop metrics that we follow continuously, and as we implement programs, evaluate the outcomes as we go. And I think that's really the direction we need to take in these systems, so that the data are flowing continuously. It drives improvement, but also drives reallocation of resources and those things as necessary. So totally I'm excited to hear that SCAN was doing that through the CCI initiative. It's so critical.
Yeah, I also want to just add on to that too. Another component of that was engaging stakeholders in the evaluation process too, of having stakeholders kind of weigh in and help guide how it was being approached. So.
Rose.
Thanks very much to Bonnie, Clemens, Wendy, and Karen. I think just to be able to go deep into CalAIM at this moment in time is just so important. And I really appreciate everything that you've all commented on. I think this is a message for Karen, and really appreciate, I think, the work that your organization has been leading and you have been leading with regard to ensuring that we get the data we need and it's reported on a regular basis. I'm curious, Karen, what your observations are, even as limited as may be, with regard to how conversations are happening at the healthcare payments data program to integrate disparities and equity numbers, metrics, and reporting. Where are we at in that space?
Yeah, that's a great question, Rose. So I think there's an acknowledgement in that space that
we need to include equity, right, in that program. And I do think that there's an understanding of where our data gaps are. I think the issue that we continually run up against, and we've even seen it in our COVID data, is how to make sure that we get more accurate beneficiary demographic data. And I think it's maybe a more involved solution than people think, right? Because asking what we find is to get from consumers responses to demographic data, we have to be very intentional about the questions we're asking, who's asking them, how we're asking them. We really struggle with things like when we ask about race and ethnicity, we're not representing everyone's identity right on our forms. And that is turning people off responding to the question, right? When you don't see yourself and your history and your community represented when you're filling out an eligibility form, right? Like those are big barriers that we really need to address. And I think, as always, this sort of data conversation does need to be community driven. Otherwise we miss really big things. I mean, I feel like you're the expert we go to, Rose, on this issue. So I'd love to hear what you think as well in terms of the solution. But I would say in terms of the payments database, I think that the conversation is happening around equity, but I do think we're going to need to go much deeper on how do we get there around beneficiary demographic data.
Yeah, absolutely, Karen. I couldn't agree with you more. I mean, this is the dilemma of other, right? When 25% or more of DHCS reported data is in other, or people do not respond, it really reflects this disconnect between who you are telling me I can be and who I believe I am. And the ability for, I mean, I think Clemens commented on this, until we get to a space where we can use data in a way, in different ways to really address the inequities, then the more these patterns of missingness and decline to answer persist in our databases, we will never get to that predictive value that we want with regard to all these programs and innovations that are being put in. We will miss who we are trying to serve. And so, if there's ways that you think that funders can use a different part of their brains and hearts in this space around equity metrics embedded in our systems, we definitely want to partner with you, continuously on that. So thank you very much.
Other reflections or thoughts from speakers or attendees on that or a different topic?
I have maybe a question to, it came up in a couple of the reflections, or maybe all of them actually, just around the ARPA dollars that are coming down. And certainly as a foundation where I think we probably all are very interested, in distribution and how they really get down to close to the community as possible. And I heard it mentioned in a couple different ways of, could they be part of helping, to solve some of the gap, I think in LA County, maybe Clemens, you raised it, and Kieran, I think in other ways, right? How are we thinking about the ARPA dollars? So I just wondered if maybe we could explore that for a minute, just on how do you see connections to CalAIM or the sort of financing piece if we're building a system rooted in equity where ARPA dollars could really come to play. Or maybe that's another conversation for another SCG event. It could very well be too.
I'd love to start it here, and I'll just say really quickly, Wendy, I'd love to start it here and have other attendees share what kinds of, we are actively thinking about what kind of ARPA programming we need to be doing related to to some of the issues that we're talking about like today. So would love to surface some questions or thinking that folks are having around that, at least at a high level, start the conversation a little bit. Wendy, sorry about that.
Oh, no, that's okay. And there's so many different funding sources that I might be mixed up about what dollars are what, but we were going just through our community benefits program where had just put out an RFP to fund, vaccinations and community-based organizations to give vaccines. And then like just as, you know, we finished our RFP and got all the proposals in, it's like, here comes ARPA, and like tons of funds, you know, for vaccinations. So instead of scrapping the thing, we just changed our focus to really focus on equity issues, to really focus on vaccine hesitancy with a particular equity lens, like trying to really address, you know, issues of, you know, reducing that equity gap. So we're trying to work around it and sort of fund equity aspects that aren't specifically you know, addressed by the money, but.
What other questions are coming up or thoughts are folks having around this topic?
I'll just say that in LA County, it's a little early. The dollars haven't been allocated. There's a whole host of programs. I think there's like 30 to 40 programs in ARPA. And so within that construct, there's some that are sort of specifically allocated towards departments to sort of do very specific things with. And then there's a pool of about $1.9 billion that is more flexible. And so the board CEOs, the Chief Executive Office for the county has been really working through taking input from the board offices and from the departments on how those dollars can be used. I don't know to what extent the community input is being requested outside of, you know, departmental sort of settings where that happens, but that funding, the allocation of that won't even hit the board for another 2 months. The thing I do know is that they're going more slowly with it because unlike the CRF dollars, the COVID response fund dollars that came last year, we're not in the midst of the same emergency, and the funds do go through 2024. So they're trying to take, instead of the more knee-jerk reactions, the emergency funding that came the first time, they're trying to be much more deliberate and intentional about the investments that they make through that fund. So not a lot of details in terms of how it's going to be allocated at this stage.
The only thing I would add is that there's a ton of flexibility, I think, to a good chunk of the funding, which is a little bit of a double-edged sword for communities in terms of we can meet community needs, but we also have to have, I think, a higher level of participation, engagement, and also accountability and oversight for the funds. You know, with previous funds, COVID relief funds, we saw here in Sacramento County, I mean, we saw all of the Sacramento County funds go to the Sheriff's Department. It's things like that that I think we're really going to need to all engage and make sure, as at least as we're thinking at it, that these funds really are a down payment for racial equity.
And I think we actually have a link to a commentary you wrote to that effect, so I'll drop that in the chat. Other thoughts? I know we have, oh yeah, go ahead.
I just want to do a little advertisement for another initiative that we have that's sort of adjacent to this. And earlier in the conversation, we were just talking about increasing capacity. And we have an initiative that we did last year, and we're going to do again this year, called the Equity and Resilience Initiative. And it's not specifically around CalAIM, but it's really meant to address the underinvestment in among philanthropy in I don't know the term of art anymore, but like people of color owned community-based organizations. So this is an initiative that specifically targets community-based organizations that are led by you know, people of color and primarily serving. And so because there has been an underinvestment in these types of organizations, and it's all about capacity building and addressing equity issues, but really just investment in these organizations that have been sort of underinvested in, if you look at data on the distribution of dollars. And it's meant to build up that capacity so that they do become more competitive applicants for RFPs and are able to join our service networks in a more robust way. So that's something that we're doing that we're kind of proud of, that I would encourage others to, you know, do the same or learn a little bit more about what we're doing.
Thank you, Wendy. I'm not sure, Richard Thomason, if I can put you on the spot. I know you're here And we are interested in hearing, I know Blue Shield has been doing some thinking and maybe has research that we could share with attendees afterwards. Will you share a little bit about your work related to CalAIM and the specific focus you have?
Yeah, sure. Thank you. So, yes, as some of you may know, Blue Shield of California Foundation has a somewhat unique focus on how do we better address the needs of domestic violence survivors in California, and how do we think about preventing domestic violence through a variety of mechanisms, including investment in behavioral health and other kinds of services. And so we've taken a look at the CalAIM waiver proposal with that lens of thinking about what are some ways in which the CalAIM proposal and Medi-Cal more generally can use these population health management program requirements that are being discussed, or the in lieu of services, and think about what are the specific needs and opportunities for linking with domestic violence organizations, and better thinking intentionally about the kind of unique needs for survivors, especially around confidentiality of services that could result in their needs in Medi-Cal being better addressed. And so we actually submitted comments ourselves as a foundation on this topic, and working with Mathematica and Futures Without Violence on those comments. So happy to share them with the group, and happy to share them with Clemens and Wendy and others on this. You know, I don't know if I have a question so much as curious, Clemens, kind of how you're thinking about the work that the county is doing with community-based organizations, and kind of the needs and opportunities that you're seeing, transitioning some of that work into the new CalAIM opportunity.
Yeah, I mean, there's two spheres of work. One is a set that we really have tried to launch through Whole Person Care, and then really were able to make a pretty significant investment through COVID. And we created a COVID equity fund where we contracted with public health, 51 different organizations, really small CBOs that don't have county contracts, under $1 million budget, but really deeply rooted. And we worked with them to sort of get the word out around testing and vaccination. And we funded them generously. We funded them, over $200,000 over the course of a year to do this work, with the idea that some of that was going to build that capacity so that they could then take on other initiatives down the line. For that group, there aren't very clear sort of sustainability pathways, right, for this work, although they've just been incredible partners. We also did another scope of work where we paid a group of 225 organizations $10,000 just to get messaging on it. We created sort of the social media toolkits, and they did all that work. And again, another group of organizations that don't always contract with us, some of them do, that we don't know quite how to continue and build off of the momentum that was built around COVID and in addressing those equities. Where we do have obviously some opportunity is within our contracted entities that provide housing, intensive case management, and reentry related services. And in those buckets, I do think there's still an opportunity to help build their capacity, the organizations that are already contracted. Some of them are quite large, right, organizations, and others are small, but helping them sort of do the work. It obviously is just a very different type of, in those two buckets. And we'd love to do more of the former, but I don't think there's a lot of opportunity in CalAIM outside of maybe year one, sort of if we really wanted to allocate some of these PATH or other funds to that specific purpose. There just aren't a lot of funds there. And I'd be interested to hear what Wendy thinks, but I don't think that there's a lot of opportunity for that investment outside of these incentives and we just would have to make that commitment. So. Did that answer your question? Or I'm not even sure.
We have about 3 minutes, and I see a message from Christy. Do you have a question you want to share?
Hi, everyone. Tremendous discussion. Really appreciate it. Christy with HealthNet, overseeing their corporate giving, at least for the LA County, Southern California region. Not at all a CalAIM expert, so this has been a really great call for me, but I wanted to share a little bit about what HealthNet is doing and partnering with CBOs, other funders, in preparing, for the ECM, ILOS shift. And we, partner, I think we have CCF here kind of figuring out how we can partner better with clinics that are already partnered with CBOs in the homelessness space, working with community clinic associations and seeing how they're kind of doing an assessment, who's ready, payment transformation, things of that sort. Looking into pilot programs. I know we were exploring a grant with Soledad Enrichment Action, like what you had said, with community health workers with lived experience, gang interventions, justice involved, seeing how those folks with lived experience can become certified health workers. So a lot of moving parts, at least within our space, on how we're exploring it, definitely in the pilot space. I guess my question is, I'm hearing a lot of evaluation or data that may be coming up as more folks are doing this and funders are doing this. Is there a space where we can share that? Is that something that SCG can kind of be the hub for that? Would love to just kind of have that one space where we can share information and then contact other folks who are doing the same work.
Thank you. We are just have 1 minute, so I'll leave space. I'm happy to follow up with you, Christy, but want to leave space if any of our speakers or anyone has a quick reflection on that. Okay, I'll follow up with you, Christy. I appreciate that question for sure. I just want to thank everyone. We are at time. I want to thank our speakers so much for your really valuable expertise in this in-depth discussion that's so timely. And I want to thank Bonnie for elevating this issue to us at SCG as something that we should really jump on and be talking about. So thank you all so much. We would really welcome your feedback. We're always tweaking these sessions to try to make them valuable for you, especially in a virtual world. So you'll be receiving a follow-up email from my colleague Bethany that will have a link to this recording. So you can rewatch pieces if you'd like. It'll have all the resources that were shared in the chat, and it will have slides. It will also have a link to a really quick survey. If you'll share your feedback that way, or feel free to drop me an email. I put my email address in the chat. We just really welcome your feedback and constantly use it to shape future content and the structure of these sessions. So thank you all so much for your time, and we'll look forward to seeing you at our next quarterly Health Funders conversation in 3 months. Take good care, everyone.
Thank you, everyone.
Thank you.